Good morning. Welcome. Let's get started. It's like a fabulous buffet this morning. Thank you, all of you that managed to get here so early. We're really excited to talk about getting past just the pilot phase in virtual nursing, and we hope that you kind of see yourself and those that are speaking this morning, so you can relate to them and say, okay, if they can do it, I can do it, and stand on their shoulders and catch some hints from them. So really excited to get started. We put their bios on the tables so you could have that, and we can just kind of dive right into the content in the session. And then we had some outcomes scrolling on the screen, and that we'll put that back up at the end too, because we want to take this short period of time and really answer the questions that your burning questions. So I'm going to just start and ask the panelists to introduce themselves briefly, but also talk about where they're at on their virtual nursing journey right now. So why don't you take it away, Marie?
Good morning, everyone. Oh, thanks. I'm Marie Foley-Daniker. I'm the Chief Nursing Officer at Hackensack Meridian Health, Ocean University Medical Center. It is my privilege that we were able to go from pilot to scale. We started with one unit, and we're now on the journey to 4 hospitals with currently 147 beds, but with a phase plan for an additional 400 in phase 2, and in phase 3 moving to 800 beds across our network. It's really been our pleasure to be kind of on this journey with our partners, and I look forward to see the work that you guys bring in the future for your virtual nursing journey.
I'm Amy Hassel. I'm from UC Health. So UC Health is a 14 hospital healthcare system in Colorado, so from the West. And we started our virtual nursing journey probably around the 2016-17 timeframe. So we were a little bit earlier. We were before the pandemic. If you fast forward to today, we have kind of 2 arms that we can talk through in our virtual nursing programs, but we have more of a surveillance program for sepsis and deterioration. That's what we started with. We surveil about 2,200 beds in our healthcare system. So all of our acute care, all of our PCU or step-down level, we surveil in the background with those programs. And then during the pandemic, in response to some of the acute care challenges we were having, as well as many of you, we started a virtual admission program, which includes med reconciliation and some other quality items. And we actually just scaled that to, we have it at 1,600 beds across our organization today. So happy to be with you all.
All right, that's weird with the stand, so I'm taking that off. I'm Tamara Denseth Rosenbaum. I'm also with UC Health, Colorado. So you already know a little bit about our organization. Amy neglected to let you know her title. She's our Chief Nursing Officer for our Virtual Health Center, and I'm the System Chief Nurse Executive for all of our hospitals and ambulatory care areas. I think I've been in this role just a little over a year and a half now, but with the organization for almost 20 years. I think what I have taken away significantly with our virtual platform is that we ask ourselves the question when we talk about developing new roles or developing processes around patient safety and so on is, can we do this virtually? That's the first question that we ask. Of course, we need boots on the ground individuals to do the work in some respects, to do that kind of day-to-day activity, but what we can do virtually, we like to think about that first. And see if that's a possibility. So I think something for you to think about. If not virtual, why not?
Good virtual first kind of mentality. Why don't you keep the mic, Tamara, and let's go back to the origins and what prompted you to get going at scale. It was pre-pandemic, as we mentioned. So what were the stakeholders that you needed, and also what were the external market drivers to do this for you, which might be different for others, but.
Yeah, so, you know, you have to have really good executive support to really land a virtual program or a virtual platform to scale the way we have. So we have a senior executive group, we call it SEG, and we have our a chief informaticist. We have actually a full-on innovation team led by one of our emergency department physicians. And we talk a lot about innovation, partnering with partners that have the technology to be able to do some of the things that we want to do. And so you have to have that buy-in from your executive team. I was actually just corresponding with one of our CFOs this morning who asked about some budgeting, my favorite time of year for budgets, but asking about some budgeting processes and why some of our nursing units received a bump in their units of service for the virtual platforms. His comment was, the virtual person is doing the work of the nurse. You've got to get that out of your folks' heads, because while they are, our virtual team is very much complementary and is part of our bedside teams, they don't do all of the work. And so it's important to kind of flip that mentality. And fortunately, our senior executive group has that mentality. We want to invest in our virtual platforms. We want to invest in innovation. So it can't be one of these things that nursing's just going to pay for. It's more than that. It's that true commitment to innovation and to technology. So I think I answered your question, Elizabeth.
And Amy, you were there back in early on, and what was going on in Colorado that kind of prompted you to need such a robust virtual care program?
Yeah, I think the specific driver at that point was in Colorado, I'm sure similar to many of your states, that our patient population, or our actual, not our patient population, our state population was actually exploding, which was creating more patients. So we were actually in the business of building 3 new community hospitals. And our senior execs that Tamara just spoke of took an opportunity to say, hey, can this be our platform for digital health? Can we start to capitalize on that piece of it as a driver? So we did a EICU, centralized telemetry and telesitting, as kind of our first 3 core competencies. But I will tell you, to go from talking about pilot to scale, when we opened our EICU back in like the 2017 timeframe for a pilot, we had 1 ICU nurse and a physician monitoring 8 patients. And so it was very small scale to start, and then obviously we grew from there. But I would just say we had really good foresight from our senior leaders about this will be the future. To be honest, it served us very well during the pandemic because we had our virtual sepsis and deterioration programs scaled. And so we were able to help our acute care nurses and just everybody during that time frame when patients were so dynamic, especially at the beginning, and we didn't know when they needed intubation. And just we actually built some tools on the fly to help kind of identify that. So it has served us well. And then if you fast forward to today, we have about 16 service lines, and we do virtual RT, virtual wound care, virtual primary care. Like, we have just kind of a whole suite of all, in hospital or to home. So we've kind of developed from that executive lens that, back in 2016, 17.
Before I move to Maria and New Jersey situation, you have a hospital that's like ski in, ski out, like steamboat. And so I think there might be this misperception that you all are just like have it easy and that your payer mix is fabulous. And that's why, like, oh, they can do it because of that. They can invest in virtual care because you have like your affluent health system.
Yeah, not so much. We're not as bougie as maybe people think we are. We have some bougie regions, but in our southern Colorado region, at the hospital that I started in, our payer mix is 75% Medicaid. So we definitely have that Medicaid population. We do have other regions that don't have that payer mix, and that helps for sure, because you do have to have money to invest in this. But I would say that our little ski in, ski out hospital is pretty sweet, and it's a lot of fun. In the nurses station, little anecdote, they have a live feed to a couple of the ski areas, so you can see what's happening on the mountain. It's pretty cool.
If you need to call in sick tomorrow.
Exactly.
So New Jersey is completely different.
A little bit different. We're located along the Jersey Shore. No laugh, don't insert joke here. The Jersey Shore is nothing like the show, I swear to God. But Our payer mix, it is diverse. I mean, we are in the New York metro area. New Jersey is the most densely populated state in the nation with a payer mix that represents that. Our journey really started different than Colorado. We are fortunate to have a visionary leader in Bob Garrett, and our CEO believes innovation is in our DNA, and honestly was at the forefront, which helped us drive alignment right at that gate. Yet at heart, finance drives everything behind the scenes. So, Bob can say, let's go, but he wants to see those numbers. So to us, it started with really getting stakeholder alignment and building the case. So building the case for us meant that obviously starting with nursing and nursing ops, leaning into finance, strategy, our IT strategy division, our EMR, our quality, you name it, coming together to build a great business plan to determine in our market what will be effective and what will generate a substantive return on investment was essential in us achieving a go. Starting in a pilot, and then we started in a pilot. Our model is really task-based. That's where our nurses' needs are. Where we saw it is that high throughput environment and the need to support our nurses in med-surg and tele and the grind that is. We really see that nurses at 12 months are trying to move out of those areas into specialty where there's a perception that the grind it may be easier, but I would argue it's not easy, it's just different. But we need staying power in med-surg tele, and we need that intelligence and that knowledge there. And what we need to do, those nurses are telling us with their feet, they're looking for a different situation. Yet we need that continuity in care. So building a model that is really an administrative support for the nurses so that they can focus in care is help driving our staying power for our nurses to stay in place and helping us achieve our return on investment for this. I will say, New Jersey, we are really competitive as a market. We're dense, so all these hospitals are on top of one another. I love my friends, but we compete every day for nurses. Nurses vote with their feet. The number one thing is their work environment, followed too by pay, right? So having many options in New Jersey, we really hold each other to account to provide a compelling work environment, and seeing what the length of stay drivers are and how that paradigm has shifted over the last few years for the bedside nurse. We see this as a stay plan, and to become more effective in driving length of stay as one of our big offsets for costs for this program, which we're great to achieve.
Yeah, I think not a lot of new grad nurses have the aspiration to get into med-surg and make that a full career. And so we got to make med-surg sexy again. And so if you can start, again, like it was ever sexy, but you got to really start to make that and if you lead with technology and innovation there, I think it is very appealing as a place to get started in nursing and stay longer. Let's talk a little bit about the infrastructure. Maybe we'll start sort of with the technology and workflows, leadership, infrastructure, governance, and then staffing is going to be a whole nother question. So do you want to start with your kind of technology and the infrastructure governance?
Sure. We did pivot after our pilot based on the lessons learned, and as we moved to scale, we did our model. And I know UC Health, you're going to talk about building it internally, but looking at where we are and our appetite, we chose to partner with Avishore. We had a great history with Avishore for Telesitter, and it seemed like a natural progression, and it aligned with our IT strategy to scale with virtual nursing using the Avishore platform. To that end, I know we're going to talk about staffing a little more later, but we also chose to use Equum as our nurse staffing partner, and they've been great partners for us to provide those services. Quickly we did feel if I was to stand up virtual nursing, I was going to pull those experienced nurses further away from the bedside. The group I most critically need at the bedside, I'd be pulling from, and then I'd be backfilling with travelers and premium and overtime, which really would have harmed my return on investment case for virtual nursing. So we chose to outsource our staffing to support the nurses at the bedside as a stay-in-place metric.
Okay, great, yeah.
Wait, can I just add a little
Sure,
thing?
yeah, please.
Getting to this, I will tell you, the scale of this, to bring this to a network level, the pilot was one little thing, stand it up, but as a network, we have 5 full-blown project teams to get this done across our network, and to get alignment to one platform with one operating strategy takes a village. You need tech teams that are working on the hardware, the software, the install, the servers. I know a whole new language now I never knew. Cluster and cloud, you name it, we got it, from hardware to software as a service. On one side to then nursing operations, everything from deployment to scheduling to transparency with the state related to our staffing, to the clinical workflow bill, and to how we communicate directly with our virtual nurses. All those elements are essential. And having your partners at the table from your technology and Avashore and Equim and then frontline nurses and the leaders of those individual departments thinking and working to build that model is really crucial to gain buy-in and operational success from the day you go live.
Oh, that's so much you said there. You talked about 5 teams?
Yep.
Can you describe what those teams are?
Sure. We have our tech build team, which is all hardware, software, server. Then that starts at the network level. Those then break out into site-based tech teams for install and continued. Then there's the clinical workflow team. Then there's the nursing operation team. Then there's the education team that, whether it's team, patient, Equim and our team members being educated. And then there's our communications team, which is our marketing and communication to the public.
Wow.
It's a lot.
Yeah. And that's across how many hospitals now?
4 hospitals now.
4 hospitals now, and
Yeah.
future phases across the system.
Yes.
Great. Okay.
Yep.
Pass it over to you. Talk about your infrastructure and governance as well. Yeah.
Yeah, we're set up a little bit differently, so it's interesting to always hear about other people's journeys. So I think just from a governance perspective, the way that when we formed our virtual hospital, for lack of a better word, we had kind of a key steer group that we brought together that has then served all of our infrastructure needs, I think has been really helpful for us. So we have our Chief Information Officer, so IT. We have our Chief Innovation Officer, who's a physician and ED training by background, runs all of our EDs across the system. Chief Medical Officer, and then Chief Nurse Executive. So you've kind of got the support you need from whatever lens. So it's huge change management in all of our work. So we have nursing leadership, physician leadership, the IT infrastructure, and then innovation. So we do a lot of beta testing for innovation. So we'll be kind of the sandbox area for AI and different things that we've done over the years. So that's sort of the innovation lens. So it works really well together as sort of the key players that help us make decisions, help us strategize, things like that, or get resources. As far as infrastructure, I think we're lucky. Again, our CIO is pretty visionary. We have a single instance of Epic. And so that really allows us to be very effective as far as when we deploy our tools and things like that. And so when we use Epic Monitor, and things like that from an infrastructure. To your point, we actually do source or staff all of our roles in-house. We encourage job shares in our different environments, but we also have people who like to do this work just specifically to do this work. So we have things kind of set up, but all of our job descriptions and things like that actually are very similar to brick and mortar, so we can make that transition kind of seamless from an infrastructure perspective, and we don't run into HR issues when people float or they want a job share and things like that. So we've been pretty thoughtful and intentional about that piece of it. And so when we started our journey, we had the fortunate of meeting Avashore. And so when we started with telesitting in 2016-17 timeframe, and then we quickly started using them for our virtual sepsis and deterioration program, where our strategy now, and I don't know if you're similar, and you guys probably all have similar infrastructures, but new build or refresh, we put a camera in every room. It's just part of our care delivery model. Our legacy aspects have mobile cameras, so we do have a mixed fleet of that and have to manage kind of both ways. But we found real value in flipping on the Avashore camera for virtual sepsis and deterioration as part of our tools, so we can visualize. Our ICU nurses can see those patients, assess them, just like you're a charge nurse rounding, and you get to lay eyes from the door. So it's been hugely helpful to us in our journey, and I think a huge driver of why we've seen such an improvement in our outcomes having that video aspect. So anything you'd want to add, Tamara?
I think as far as infrastructure goes, being able to pivot fairly quickly, we've had some outcomes for patients that were less than optimal that we have quickly pivoted. I'll give you an example. In the deterioration model that Amy is speaking of, we had initially the way we set that up was the virtual health center did not call the RRT or the rapid response team. We had the virtual health nurse call the bedside nurse, and then the bedside nurse would go in and assess. That was leading to prolonged time to get to our sepsis bundle, to get to fluid resuscitation and so on. And so, Amy, to Amy's point, we got our group of 5 together, and we said enough. And within probably 2 weeks, I think it was, we completely pivoted, and the RRT was then called by the virtual health center as soon as they saw deterioration happening. And Amy will give all the data a little bit later. But I think that being nimble and understanding that you may not get it right out of the gate is okay, and having a governance structure that can be quick to identify issues and then change process is really, really important.
Absolutely. Yeah, that's a great example. And just like a telemetry tech should be able to call a code if they are, seeing VFib and verify it, or a virtual sitter can call an elopement when the patient's gone, and same thing with but that is a culture shift. So that's a great example.
Yeah, we didn't want initially to pit the virtual health center against the VHC nurse against the bedside nurse. And so that was, our thought process initially, but we pivoted and said, no, the VHC is part of the care team.
Yeah, and that's a patient-centric decision.
Correct.
Yeah, and I'm wondering if, as you scaled, Anne Marie, what aspects of your original plan did you change?
We changed a few things. I mean, honestly, first started with listening to the nurses, what they found value in and what they found that they were underutilizing, and then leaning in to maximize where the value was. So for us, it was the ADT function, those admissions, discharge, transfers. Getting them the opportunity to get back to the bedside was really where the buy-in was from the nursing staff. Starting there and then letting the business case follow. So, seeing the improvement and this was our pilot where we started was a really efficient unit. This was a unit that had a observed over expected index of a 0.95, and we dropped it to a 0.84. So we really, the churn of patients, the throughput on this unit is impressive. But the quality of life for the nurse definitely is, they feel more value in what they're doing every day in connection to patients and in being able to focus. That being the one. And then 2, seeing the traveler reduction, seeing the lack of dependency. I mean, for New Jersey, we know we're in a deficit of nurses. We know we're going to be there for the next 5 to 10 years. And knowing, travelers, that's not a sustainable model, and it's not strengthening our workforce. It's putting a Band-Aid on it, but we really need to support the work environment is what we see, and have, maybe everybody doesn't want to be a careerist in med-surg, but we need to ensure that we're building the best of the best to take care of our patients and have a supportive work environment for our nurses. So really essential there, and listening.
Yeah, good. Speaking of your communication with your CFO this morning, when we were talking about this, you shared how you allocate your expenses, which is unique. And so can you explain how that works for the virtual care center?
Yeah, again, we had to pivot a bit, but the way it works for us is that each one of our departments that utilizes the virtual resource, which is many, but not all, we collectively as a leadership team, again, with that thought of investing in innovation and the virtual health center, each department or unit kind of got a bump in their unit of service for the virtual resource. Now, that's good and bad. What I would tell you to do if your teams invest in this concept, first off, it's a very small bump that each unit gets to utilize the FTE that's in the virtual health center. We're talking 0.1, 0.2 additional HPPD for our units of service and so on. So it's not huge. But what happened with us just most recently is in totality, we increased the units of service. So the nurse manager saw that they got this bump and they hired up to it, not realizing that was their virtual allocation.
Oh.
So my recommendation to all of you, if this is the route that you go, that it's a separate line item in your budget, so that your nurse managers don't forget that that's their allocation for the virtual resource, and they don't hire up to it, because then inevitably they're going to be over in productivity and your CFOs are going to be knocking on your door. So this year, we're doing something a little bit different. Again, a separate line item, both for the virtual health center and for sitter allocation. So my other advice to you, when you stand up a sitter resource in the virtual health center, is that you make sure that first your teams know that that is an allocation that they can't touch, because that's the virtual piece. But more than that is making sure that you have a process in place for removing that sitter resource. We're using upwards of 240 FTEs of sitters on any given day across our 14 hospitals, which is a tremendous number of FTEs. And I can't, with any confidence, go to my CFO and say, we need every single one of these. So we've done a couple of things. We have a sitter dashboard now, so when an individual clocks in, they clock into the sitter role, first and foremost, and then secondly, they clock in as to whether it's a mandatory sitter. So in the state of Colorado, all M1s and SIs have to have a one-to-one sitter. So that's going to be a way for us to tweeze out what's actually required versus what's nice to have. But Amy is now working with her team and others on an algorithm for sitter implementation and then sitter removal. Because I don't know about you, but once we put that in-person sitter on a patient, we sort of forget about it. And we don't go back and routinely look at whether that the patient's mentation has changed, and we can revoke that sitter resource or change it from an in-person to a virtual sitter. So those are kind of some little tips, but for budgeting purposes, if you can get your CFOs and your executive team to agree to give your units a bump for the virtual resource, and that's how you pay for it, because there's different methodology. You could put it in a separate cost center and let it live and breathe by itself. But we actually wanted to challenge our nurse managers to say, can you still hit your budgetary targets even with this virtual resource embedded in your targets? And more often than not, because of the nature of our business with the turnover that we have and the vacancy rates that we have, more often than not, we can still hit our budgetary targets.
And I imagine that's sort of an incentive to use the virtual, like I'm paying
Absolutely.
for it, so why wouldn't I use it?
Oh, and they let us know that all the time.
Yeah, yeah.
I would add to that. I mean, for us, we've done everything to strive to keep virtual nursing out of the unit-based productivity. You know, it is a layered add. We see it as a value add, but one of the biggest things we learned in the pilot is as you're driving throughput, that ADT function is not always accurately captured in the workload assessment, right? So you are asking nurses to move patients through more quickly, yet you are offloading that administrative burden, but it is still workload for that nurse. Yeah. You know, that transition point can't be underestimated. So seeing that and then having that thoughtful conversation with finance, like, listen, the outcome, we're going to get it. We've got it in the length of stay. We've got it in the efficiency. But that is built in partnership between virtual nursing and bedside nursing to make that case. I mean, you know, if we go in this strictly as this is, you know, we thought initially like, well, maybe this is going to be so efficient, we could tweak the ratios a little bit in time. That might be great in an experienced workforce. That I don't have. Right. I'll be very clear about that. I have a mostly novice workforce. So, you know, I can leverage and make, you know, when you go to your 5-year career nurses, man, they can make anything happen in the middle of a shift, right? But to a more novice workforce, they can't level to that peak efficiency of throughput. They need a little more support. So while they're focusing at the bedside and we're being efficient supporting them, you'll see your time to bed go down, you'll see your discharge time go down, and your total length of stay go down. So knowing we have that is really, that's our takeaway, as in how we're maximizing the beds from a finance perspective, and we're driving down our premium costs. Nurses are leaving on time. That incidental overtime, you know, that calling out for burnout, you know, seeing those metrics realign, helps drive that business case. And for us, these are costly ventures. There's no doubt about it when you start looking at this. From a finance perspective, every organization's at risk. This is not an easy operating environment for any of us. But coming into this with the conversation of what's your best target, for us, we had to re-strategize as an organization from business plan 1 to business plan 2 and say, where do we see the maximum amount of value? And for us, it became, we're going to our hospitals that are high holding. Getting those patients out of the ED, getting them up to a bed where they're safer and have better quality, a better experience. Driving that throughput as a patient metric, completely aligned with our organizational values. And then the money did follow. So, yeah.
I really enjoyed this because you have different challenges. So you're very different models
Yep.
To scale. From your governance sounds different. You guys started pre-pandemic. You're really kicking off now, and then the external staffing model, and I imagine the EQUIM nurses bring a level of experience
Absolutely.
that is really helpful for you too.
We're really lucky. EQUIM's located in Tennessee, which is a different, very different market than New Jersey. But
Yeah,
we're fortunate
right,
to have really experienced nurses. Most of them have ICU and many years of med surge, and it's a partnership. It's one Epic chat away from, can you look into this a little deeper? They can be available to mentor also.
Yeah.
Yeah.
Awesome. So I would like to just end with each of you giving what is your advice to health systems who are struggling to move beyond just the pilot mode. So you want to start, Marie?
I would say, one, listen. Listen to your nurses. Look for your opportunities to maximize your service. I'd say, two, go into this being transparent with them, knowing what you want to take away from this and what the deliverables are. You want that open, honest dialogue that you both have benefit from it. And then, know your data. Honestly, it all comes back to the data and making the case, and then being able to provide that environment that is most supportive for care.
Amy?
Yeah, I would say a couple things I think that have been keys to our success would be we have really good executive support, but we also have to really build that ground up support. So I think it's kind of, for change management and buy-in, you're going to need both. If you have just one or the other, you're going to fail. Grassroots is great, but it gets to the executive level and it fails. And executive top down makes people posture and not want that. And I would also say in the virtual world, we get thrown a lot of problems or like questions or ideas, but it really has to be a solution that is implementable. Like it doesn't add extra work to the clinicians. It provides value instead of the other way around. And so I think that's been key to our success. And just thinking through over the years. And I think and willing to pivot. You're going to have to iterate. And the one thing I've seen develop over our 7-year journey is that we've really become a nice conduit to quality. And being, as far as KPIs and business cases, it is frontline nurses with problems that we need to solve, or physician and providers. But we've been able to be a conduit and an augmentation of quality. So how do we partner when we have these intractable metrics like, the continuous whack-a-mole of CAUTI, CLABSI, falls, we all play these games and you're just like, God, can I get off this hamster wheel? And how do we put something that's hardwired, scalable for the future, especially when we have acute care nurses that are, like you said, 5 years feels really experienced now. And back when I was a new grad, that was not experienced. And so how do we hardwire and have these models that we can pivot and plug and play as new metrics come up, but we can really get traction? And so I think thinking through those kinds of items, but I really do think from a change management, top down, ground up, and meeting in the middle is going to serve you well with knowing your KPIs and understanding what you're trying to set out to solve. And having the data is key too. I think that's hard. You set out, you're all excited, but then you go to try to measure it, and it's like all this manual brain damage when you're trying to scale, and you just can't do it. So those thoughtful things I think have been helpful to us.
Yeah, I would echo that for sure. I think if you're part of a system, trying it in a couple of different hospitals, the same thing, and determining what works in one spot versus another. We have a large academic medical center and then a lot of community hospitals and critical access hospitals, and what's good for one is definitely not good for all. So I think if you're thinking of piloting in a system, do it in more than one place, because you'll learn a lot. But also set a timeline. I know that sounds really simple, but to Amy's point, you need to have your key performance indicators, and once you're getting close, start thinking about what's next, where you're going to land next, because otherwise you can kind of get stuck on Amy's hamster wheel of, continuing to try to get perfection, and it's never going to be perfect for everybody. So I think that having strong timelines with key points that you want to hit before you move on is really important. And to Amy's point too, understanding what the data is and how you're going to get that data to prove your point, because you don't want to have to involve lots and lots of people to get your data to prove that you've got this all buttoned up. So those would be my pieces of advice.
Yeah, I just thought of one other thing. I think that it's cliche, but I think if you're going to fail fast.
Yeah.
Everybody says that, but people are scared to fail. When you're doing innovation work, it is scary to be like, we're going to pull the plug on this project. We've had 2 projects over all the years that we've pulled the plug on, and one we pulled the plug on in 2 weeks from start, which is crazy fast. And it made people feel like, should we be pulling the plug? But I think if you know, like once you get into these cycles and you know what's effective and what's not, but I think evaluating that and having the courage to do that, but then go back to the drawing board and say, okay, what did we get wrong here when you're doing these types of innovation and pilot work, and then just repivoting. So
Yeah.
it's cliche, but it's hard to do.
I think it's maybe worth even sharing one of that. You were saying, I think it was the nurse was going to answer call lights.
Yeah.
So I think I've heard this a lot, like, oh, the virtual nurse can
Yeah.
field the call lights, and that'll be great.
Yeah.
So is that great?
Yeah, so that was the concept. So we thought, we have this, to your point, sexy idea for acute care is like, we'll answer call lights for you, and it's going to be so grand. And we developed all these,
Here's this gift.
like pathways and workflows. And that's the one where we went live, and within 2 weeks, I was like, this is not going to work. We've got to stop. And I felt like the acute care nurse was like, no, we can keep trying even though it's awful. And I was like, no, like, let's just stop, please. Let's just stop. Like, we're all in misery here. And so basically, we're inserting ourselves. So we have pillow speakers where the patient's supposed to be able to triage themselves, right? But we also, like, they can push for water, they can push for pain, and then it has smart technology it only goes to the CNA or it only goes to the nurse. But what we were having before we tried this is that the patients are confused, or it's too hard, or they just can't, whatever, they can't do it. So the CNA is getting the nurse is getting CNA, and it's just chaos. So we were like, what if we offload it and centralize it like we do for everything else, and we'll help you? Everybody's like, that's great, let's do it. And it was just chaos. Like the amount of secure chat and communication, the increase, and it just got chaotic, to try to air traffic control that. Yeah. And so then we sat down with the nursing leaders. Again, we pulled the plug, and they felt bad. And I said, please don't feel bad. Like, we just got to figure out. I said, the vision here is to get upstream. We want to, get dietary orders in hours before they're due. We don't want all these things we can do. And then the nursing leader said, well, why don't you just do that? Why don't you just proactively round, and we'll answer our own call lights? But then that'll decrease our call light burden. And I was like, well, genius. Why don't we just do that? So we're back to, we're going to try that, where and a lot of people have these programs, but what we're going to be very intentional about measuring is like our dietary needs and some of the pain points we have where tray orders get backed up, that affects hypoglycemia, et cetera, patient satisfaction, is trying to do proactive rounding and really being intentional around the shift change times so that we can address patients when you have that long gap between 6 to 8 on both sides of the fence, and seeing if we can help falls, see if we can help, responsiveness and all those things. So we definitely learned our lesson.
Failing fast really increases the trust of the staff. Like, we will give it a try, because if it doesn't work, I know Amy's going to say, okay, don't. Did you have one last final thought?
One last thing. So I completely agree. We tried the call bell thing too. It just felt like more work to the bedside nurse. Like, I'm just getting texted to go give water. Like that kind of thing. So, and we were doing like a rounding, like checking in every 4 hours, and it was like, oh, do you have any questions? And questions were great, but then it was task. It was just another thing for the nursing team. So we decided to keep that when we revamped our model. I will say, though, on the other side, maximizing the outcomes of the program, leaning into the strengths of it. So, like, you see a discharge of a virtual nurse, they'll spend 25 minutes going through, we're in Epic House, the AVS, the discharge education. The level of detail they'll put into it, I wish my nurses had the time to do that. I mean, that's what I'm saying. It can be a driver for readmissions. Having that time to thoughtfully take the patient and the family through the discharge sets you up for success that you don't have a readmission. Whereas, my nurses are like, okay, you got this, like 5 minutes. Like, they're trying to hit those key points as the family's pulling dad out the door. Whereas the nurse can get in there a little bit earlier before and start that whole thoughtful discharge with the patient and the family and get it done right.
Yeah.
Really well. So looking at where your strengths are, maximizing your time, and then letting the outcomes follow from that.
Yeah, and just a closing thought that I'm going to just build on that. If you're doing a tiny pilot on one care unit for 60 days, you're not going to find that. Like,
No. You need
the
6 months of
virtual
data at
nurse making better discharges.
Yep.
Lowering your readmissions, it's just not going to show
Right.
in 60 days on one
Correct.
care
So
unit.
many of these metrics are long lead
It
metrics.
is a little bit long lead metric, so it does take some
Yeah.
courage too. And I think it's all about balance. Like, so yeah, do that, but also quit if it doesn't work. So hope it doesn't sound like we're talking out of both sides of our mouth up here, but it's balance. Yeah. So. Thank you so much, and I'm sure Tamara, they will all be happy to answer questions. Thank you, guys. Do we have time? We're supposed to end it now, but if whoever wants to stay, I just don't want to make y'all late. But yeah, go ahead, but don't feel rude to leave if other people need to leave. Yeah.
I just want you to quickly describe what the virtual nurse is doing day to day. That's the concept. I didn't hear that as part of it. What exactly are they doing day to day? Some of the big pieces.
Yeah, so for virtual admission nursing in our acute care world, they're doing complete all the admission questions. But the way we have it set up, just to say it, they will get signal if the patient's been admitted in the last 48 hours. So for instance, maybe the patient comes in at 3 a.m. I admit them as the bedside nurse. I'm going to ask the top 3 or 4 questions. Are you allergic? Are you a full code? Would you take blood? Who do you want me to call? Okay, good night. I'm not going to do all of that. So they'll go back. They do social determinants of health screening, med reconciliation. So those are our key pillars that we've done. We also look for quality care gaps, which is a whole nother topic. But we will, in between doing admissions, we look for quality care gaps for Caudy, Collapsy, Happy Falls. And then we work with the local team to close those care gaps in real time, each shift, so no patients. CHD care, yeah. And then virtual sepsis, they're looking continuously with AI tools to see if there's new sepsis or deterioration and activating the response and holding the timer. Do you have?
We're a little more streamlined, so we're not as evolved. I want to get there. We're really focusing on admissions, discharge transfers, universal transfer forms, PTA med list, a lot of flow.
Yeah.
Yeah.
Go ahead.
Oh.
So I look back to what we're seeing a little bit, at least in my site, is especially from the higher level care, ICU, step down, where the virtual nurse calls in, it's almost like they're ignorant.
Oh,
Yeah.
oh yeah.
Yeah.
Build it so you didn't feel like it was Big Brother looking over you, catching you.
Yeah.
Instead it was like, I'm helping hand. The person who walked in the room is like, hey, what's this? It's not a problem.
Yeah.
That mentality, because we see that where they're almost
Yeah. We run in this in particularly in our PCU population where they're deemed as part of the critical care branch, but I'm a critical care nurse by background, and I'm like, a pressure of 60 over 30 isn't normal. Like, we don't allow that. We fix that. But it's like, these patients are sick. We got this. And so we've had to really we have the same tools and we have the same rapid response criterias for acute care and PCU patients. We've had to do a lot of change management. So we've done a lot of RCAs, case reviews, where we really do highlight to them, this wasn't normal care. So I would say it's a lot of that grassroots local, let's sit down, let's hear you out. I do understand you think like a critical care nurse, but here's some gaps we're seeing in the patient. What's best, and then bringing it back for what's best for the patient. Is it really best to sit with a pressure of 60 over 30 till the doctor comes in, because it's nighttime, and you feel like you got it? You know, that we've had to have a lot of those just kind of grassroots conversation, and with leadership too leaning in. I mean, you're going to need your CNO to lean in and support that locally. But I honestly feel like we've almost carved out a whole working group just for PCU because they feel like they're so special.
Progressive care.
And I think that they do have a challenging population. They have a really hard job. To your point, it's just different than acute care. But that's how we've approached it for that particular thing. I don't know what else you know.
I think the other thing is we have a hybrid role. So Amy hires nurses that round at the bedside and then are communicating with the virtual team. So I think that it's called a virtual support nurse. We called it a virtual quality nurse for a while, but our quality team didn't like that. So we're like, sure, fine, whatever, we'll change the name. They still do the same thing. But they round on patients, and that, I think, has also helped bridge that potential communication gap, that they're seen as really kind of helping hands for the bedside nurse to say, your patient needed X, Y, and Z, and I took care of that for you. So that was, I think, an essential bridge that we put in place a couple of years ago.
Yeah. I think the other thing is we've had more conversations with that group. The one thing that's evolved is when we get to the heart of it, what's driving some of your response? They often feel dismissed or unheard from the providers, and they don't know how to articulate the case. And so now that we've flipped and had a lot more conversation, we're like, oh, well, they would be concerned if you, instead of saying it this way, say it this way. Position yourself the right way, and we'll back you up. And so now, I mean, it's not everywhere. It's not, the Holy Grail, but I think we've made a lot of progress with we're here to support you and back your intuition up, which is usually right. I mean, nurses have that intuition. It's just, how can you articulate the case instead of just being like, hey, they have low blood pressure, and saying they've had, 10 cc's of urine output, really get those stats. And so that's been some of our journey in this space. But I agree, it's a real challenge. I don't want to dismiss that at all because I feel like it's definitely palpable.
I had the pleasure to spend a day with one of your virtual nurses, and the other thing is the video is so important for this. Mm-hmm. So you've got the virtual nurse has to see what's going on in the room. Because I think you were doing sepsis without video initially, and they would call and say, you need to start the IV because you need to get the antibiotics starting. Now they have the video, they can see the nurse is working on starting the IV or has failed 3 or 4 times, and then they get someone in. So that's where that visual, audio-visual piece is so important. So, yeah.
One other thing we did that is somewhat controversial is we record every conversation that the virtual health center has with our bedside nurses. So that will spread like wildfire in your organizations if you have a nurse, a bedside nurse, that does not exude the culture of the organization that you would like to have, and we send those recordings. That has been, I think, a game changer for us in some respects, because if we don't have that collegial conversation that's happening, we will go to the bedside nurse and say, stop it. Yeah. They're part of the team, and that has helped with the culture piece as well.
Time out.
Okay, Katie.
Oh, no. It was what we learned yesterday. Time out.
Incivility.
We don't talk that way to each other here, so you can do that virtually, too.
Thank you. We are in a pediatric cardiac ICU, and we have a lot of ideas for this. We recently brought this up in one of our senior staff, and were met with the Big Brother comment as well. Yeah. I'm wondering, what are your greatest challenges in the ICU environment? And the second question is, do you use it in pediatrics?
Well, you remember when I talked about we had 1 nurse to 8 patients? What we found, and this is kind of why this is just my personal opinion, having been a critical care nurse for 15 years at the bedside before I did any leadership roles. When I came into the space and we were starting it, yes, EICU serves a purpose as far as ICU nurse, surveilling ICU nurse, but back to the Big Brother comment, where we see more application is in acute care. So we use our ICU nurses to be our virtual sepsis, to be our virtual RRT in the sky. They do some work, But the intensivist at night is really more of the workhorse in that model that the nurses need. And there is some backup, but we find that we can really pivot their skill set more in that way. We don't monitor pediatrics, and that has been a huge ask from like community hospitals and things like that. So happy to chat with you more about your ideas, but that's kind of our journey.
Please feel free to leave if you need to get to another session, but if you guys don't mind, continue to answer questions until we get kicked out.
I just have a quick question. We are actually starting our virtual nurse program today.
Today.
And we live in a rural area. We have about an 88-bed hospital. A lot of our nurses are less than 5 years, less than 2 years experience, and especially on our night shift. So does your virtual nurses provide any support for those newly licensed nurses or new to the organizational nurses?
Yeah, I can answer.
I mean, for us, yes. I mean, that was part of how we communicated to the team, and I know we're more of a task, it's a spectrum, like virtual nursing starts task-based all the way to EICU, and we're definitely more toward the tasks, not even toward surveillance, right. But our nurses know they're a click away. If there's something they want to chat about, something they want to run by the virtual nurse who does have experience, they're available to them 24/7.
Yeah, I think, we do have a lot of contact with acute care. I think we saw this particularly during the pandemic where they would phone a friend and just ask. So they have that support there if they need it. I also think that the newer role that we've implemented over the last year and a half where we have kind of a conduit on site, it's a virtual, it's deceiving, it's a dumb name in the sense it's a virtual nurse who's in person. But they will kind of provide that support and that liaisonship as well. But they cover a lot of beds. They're roaming, so they cover one nurse covers 4 36-bed units and is closing quality care gaps, but sort of serving as that mentor. And we've seen good success for different questions in that way, too, for acute care.
Good morning. Do you all use staffing solutions, third-party staffing solutions for nursing, or do you do it internally? And what was that decision point that brought you to that place?
Ours are all internal. So I have almost, I think, 500 FTE in all of our different programs. It's all internal. The only thing we outsourced that we found in our journey that didn't make sense, we tried 2 different iterations before we outsourced, is our intensivist physician. We use a model where they're overseas and their nighttime is our daytime, their daytime's our nighttime. But we've chosen to keep everything else in-house. For us, and I know your journey's different, so I'd be curious to hear what you think, but we just feel like it's our own staff, and it encourages recruitment, retention, it's our own staff, we can do job shares, all the different, it kind of gives us more versatility. And so I think for us, we've just chosen to go that route. I'd be curious what you think.
Again, I think it's about your market, right, and understanding what your workforce needs are. For us, outsourcing was the better option. The price in the New York metro area and knowing where our vacancy and knowing what our long lead nursing shortage is in our region put us down the path that having a partner was a more successful strategy to not undermine and pull nurses away from the bedside that we so desperately need.
What I've seen too is in between there somewhere might be some organization that wants to get started quickly or, maybe do a pilot and proof and they might outsource for that with a plan maybe of moving towards internal staffing long-term or at scale, but it's a way to get started more quickly as well.
Let me
That's
add one more thing. Trust is earned, whether you're an internal virtual nurse or you're a partner virtual nurse. Those relationships, you can't underestimate them. I mean, if the nurses need to have trust in their partners.
So my question's related to that, because you guys are doing internal staffing, and I think you mentioned that you have hybrid roles as well. Do you find that then helps the relationship of like less Big Brother because they work side by side with some of those people? And like how that influences that?
Yeah, I mean, absolutely. I think, today you're here, tomorrow you're back at the bedside. And we actually did our virtual wound care and RT programs FT neutral. So they're just like one big team that's coming off the floor at our center. So absolutely. They understand the pain points, the culture, and things like that. I think and they also get a bigger appreciation. So a lot of our job shares come from the academic campus. They've never seen a community model. They don't understand the challenges in a community model. But then when they go to virtual nursing, they're like, oh, like you don't have a doc all the time? Like they don't, it's just like mind blowing to them. And so it really elevates their lens too, to think a little bit bigger. So when they go back into their environment, they have a little bit bigger lens of like, well, you know, at such and such hospital, they're kind of the cool kids that have all that knowledge. So I think it's elevated practice in that way.
Oh, thank you. We're starting ours today as well. So it's a journey. I just want to understand the ratio between the virtual nurse and I'm not sure if I missed that a while ago.
We didn't do, yeah.
Yes. So the virtual nurse as to the patient, and also how does it look like with the bedside nurse? Did we change the ratio?
Let's talk about that R word.
Do you want to?
You go first.
Okay, I just feel like I'm the only one talking, but okay, so for our virtual admission nursing program, it's 1 acute care nurse to 225 beds, which sounds exorbitant, but we're able to do that and keep up, and it's because we're getting signal within the last 48 hours, so we can kind of keep playing catch up. So our ratios are much different than some of the other models you'll see where they're much leaner, because we're really focused on our 3 key things, you know, that we're doing, which is admission, social determinants of health, and med rec. So it's 1 to 225. In our virtual sepsis and deterioration program, we did not start at these ratios. We started at about 1 to 150 beds that they covered. We're at one ICU nurse to about 500 to 600 beds. In theory, that sounds weird when you're not used to virtual nursing, but it's because the tools are always looking in the background and then only bringing forward patients who are meeting the threshold. So we've done a tremendous tweaking with our IT team, with our AI tools. You know, it's really helped. It's the technology that's augmenting those kinds of ratios. We had already started changing in the pandemic timeframe, started changing some of the ratios at the bedside, and this augments when they have those change ratios. So they were kind of 2 separate initiatives. Our typical ratios, I don't know if you want to talk about that at bedside.
Yeah, for acute care, it's usually 5 to 1. And then for critical care, of course, it's 1 to 1 or 2 to 1. So those are our typical, you know, perfect world kind of staffing matrices, which we all know don't exist. And charge nurse, of course, doesn't have patients and all of those wonderful things. So that's kind of our typical bedside in acute care and critical care.
I would just say the biggest thing we saw for ratio changes when we started implementing virtual admission nursing and getting it truly hardwired is we had 2 roles. We had variations of somebody who would be an admission nurse. That was supposed to be their job. But really what they were trying to get at, and they kept getting pulled into everything else. So what the unit was trying to do was to staff a resource nurse to help with hotspots. They would label it admissions, but it wasn't like they consistently got to admissions. They would get pulled into the rapid response, or somebody needs to go to CAT scan, or somebody coded, can you help me? Somebody needs to go, you know, just whatever was going on. And so we finally said, let us take on admissions, like all the way, and you get back to the bedside with your hand, you know, have your hands at the bedside. So that started to resonate. As it took some change management to get there, but we saw them stop staffing. It's still at work. Most units don't do this anymore. There's maybe 1 or 2 that's still out of the 50-something, but admissions or resource nurses, stop, you know, put those people back. Those should be hands at the bedside. That's what you're trying to accomplish. Or decrease your ratios, have better ratios for that day. Put them back into the mix for staffing. Yeah.
So for us, MedSurg is 5.5 to 1 and tele is 5 to 1. I will say going into this, you know, there was hope from finance that we could tweak that. What we demonstrated is we can't. We can't. You know, in a novice workforce, that efficiency to level up is not there. But you can gain many other things from providing the efficiency of a virtual nurse. So our staffing model is, again, it goes back to the data yet again, looking where, you know, we went into this projecting X amount of admissions and discharges per day, and then Equim responded building a staffing model around that. Yet they're responsive to us and seeing, you know, on one unit, most of the discharges are going out in this time of the day. Another one, they lag behind that. So, you know, looking at that and then them being able to reposition based on where our plan, it's not, you know, long-term, where those unit needs are is how they deploy their staffing. But short-term is even hospital to hospital. So like, you know, at Ocean, we know Monday's a big surgery day. Yet at Jersey Shore, Tuesday on this unit is a big surgery day. Knowing when those surges hit, those nurses will cross campuses to help back up another nurse. If there's 6 discharges at one time at one campus and there's only 2 at another, we'll try and shift those nurses to help support where the peak volume is at those times.
I might have missed this early on, but for the virtual nurses, do you have like a physical location that they're located at? Are they remote? Is there a mix?
So the way we approach this is our techs and nurses are all at it's about a 5,500-foot command center. It's not on campus. It's in an office building that we own because the campus real estate is too, just too valuable. And, we're in a very nondescript office building. We like to joke we're like the CIA because it looks pretty plain. But it's exciting what's going on. We have our providers, our APPs and physicians. They're typically remote, and that has served us well. There's different models out there of what you'll see. I just personally have found from like a productivity standpoint and just having line of sight on folks' work that we keep our technicians and nurses on site. We do. We actually, so what we're starting, and we just did a pilot of about a pilot of 100 patients, but now we're scaling. We're doing a virtual transitions care program. So what we're starting to do is flex play that virtual admission nurses and different resources, looking at pharmacy coming into the fold to do a virtual transitions of care program and support that patient. So we're looking at both, it'll probably be, we haven't gotten to the discharge part. We're just picking up like once they're gone, following them through and making sure they get the transitional care medicine visit done within 7 days, and making sure we don't have leakage from our healthcare system, and just that people have the proper support. Where this will go is I think we can capitalize on the HCAP questions of there's two that are nursing driven for meds that we need to hardwire and start to make sure that we're hitting it. Like, do you have any questions? We know you had a new medication. How are you feeling about that? But to her point, not at the time of discharge when they're being pulled out the door and they're like, I gotta go, my grandson's here. When they can really focus and they're in their natural environment, they've had a good night's sleep.
Thank you so much for staying late.